Meningiomas. Meningiomas are the most common benign intracranial tumor. They originate from arachnoid capsules, which are cells within the thin spider web-like membrane that covers the brain and spinal cord. The arachnoid is one of three protective layers, collectively known as the meninges, which surround the brain and the spinal cord. The other two layers of the meninges are the dura mater and pia mater. Although the majority of meningiomas are benign, these tumors can grow slowly until they are very large if left undiscovered, and in some locations can be severely disabling and life-threatening. Most patients develop a single meningioma. However, some patients may develop several tumors growing simultaneously in other locations of the brain or spinal cord. Some meningiomas are found along the dural lining in venous sinuses of the brain and skull base, locations where arachnoid capsules are most abundant. The following subtypes are based on the location of the tumor. Cavernous sinus meningioma occurs near the area that drains deoxygenated blood to the heart from the brain. Cerebellopontine angle meningioma, located near the margin of the cerebellum. Acoustic neuromas are also frequently found in this area. Cerebral convexity meningioma, located on the upper surface of the cerebral convexity. Foramen magnum meningioma, located near the opening at the base of the skull through which the lower portion of the brainstem passes. Intraorbital meningioma, located in or around the eye sockets. Intraventricular meningioma, located in the fluid chambers that produce and carry cerebrospinal fluid throughout the brain. Olfactory groove meningioma, located along the nerves connecting the nose to the brain. Parasagittal or fax meningioma, located adjacent to the dural fold that separates the two brain hemispheres. Petrous ridge meningioma, portion of the temporal bone that contains sections of the organs that facilitate hearing. Posterior fossa meningioma occurs near the back of the brain. Sphenoid meningioma, located near the sphenoid bone behind the eyes. Spinal meningioma, located in the spine, in some cases against the spinal cord. Supracellular meningioma, located near the area of the skull where the pituitary gland is found. Tentorium meningioma, located near where the brain connects to the brainstem, an area known as the tentorium cerebelli. Types and classification. The World Health Organization classification of brain tumors is the most widely utilized tool in grading tumor types. The WHO classification schemes recognizes 15 variations of meningiomas according to their cell type as seen under a microscope. These variations are called meningioma subtypes. The technical term for these cell variations is histological subtypes. These histological subtypes are organized into three grades that generally reflects the rate of growth and likelihood of recurrence based on cytological features. Atypical meningiomas, WHO grade 2, which account for 18% of meningioma cases, exhibit increased tissue and cell abnormalities. These tumors grow at a faster rate than benign meningiomas and are often characterized by brain invasion. Atypical meningiomas have a higher likelihood of recurrence than benign meningiomas, WHO grade 1. Malignant meningiomas, WHO grade 3, show increased cellular abnormalities and grow at a faster rate than benign atypical meningiomas. Malignant meningiomas are the most likely to invade the brain and recur more frequently than the other two subtypes. Prevalence and incidence. According to the Central Brain Tumor Registry of the United States Statistical Report of tumors diagnosed in the US in 2012 to 2016, meningiomas were the most frequently repeated overall histology, 37.6% of all primary central nervous system tumor, with 33,560 cases projected in 2019. The average annual age-adjusted incidence rate was also highest for meningiomas, 8.6 per 100,000 people for all primary brain and spinal cord tumors. Additionally, these incidence rates of meningioma were observed to increase with age, with a median age at diagnosis of 66 years. The majority of meningiomas with tissue confirmation are non-malignant, with 1.7% confirmed to be malignant, WHO grade 3. Risk factors. The risk of meningioma increases with age, with a dramatic increase after 65 years. Children aged between 0 to 14 are at lowest risk. African Americans have been observed to have higher rates of meningioma than other ethnic groups in the US. Exposure to ionizing radiation, especially high doses, has been associated with a higher incidence of intracranial tumors, particularly meningiomas. There is also evidence indicating a connection between meningiomas and low doses of radiation. The most well-known case involved children in Israel who were given radiation for scale ringworm between 1948 and 1960. Within the US, dental x-rays are the most common form of exposure to ionizing radiation. A number of studies have linked the number of full-month dental radiographs to increased risk of meningioma. The genetic disorder neurofibromatosis type 2 is believed to put people at a higher risk of developing meningioma. Patients with NF2 also may be more likely to develop malignant or multiple meningiomas. Per the Science Foundation, a number of studies have suggested a correlation between meningiomas and hormones, such as the following. Increased occurrence of meningioma in post-pubertal women compared with men. A higher female to male incidence ratio during reproductive years that disappears with increasing age. The detection of estrogen, progesterone, and androgen receptors in a significant number of meningiomas. A link between breast cancer and meningioma. A connection between meningioma growth, menstrual cycle, and pregnancies. Researchers are beginning to explore the possible connection between meningioma risk and use of oral contraceptives and hormone replacement therapy procedures. Furthermore, an association between obesity and meningioma incidence in several large studies indicates a possible underlying relationship. Symptoms. Because of meningiomas commonly are slow-growing tumors, they often do not cause noticeable symptoms until they are quite large. Some meningiomas may remain asymptomatic for a patient's lifetime or be detected unexpectedly when a patient has a brain scan for unrelated symptoms. Presenting symptoms and symptoms depending on the size and location of the tumor. Symptoms of meningiomas may include headaches, seizures, change in personality or behavior, progressive focal neurologic deficit, confusion, drowsiness, hearing loss or ringing in the ears, muscle weakness, nausea or vomiting, visual disorders. Symptoms can be related more specifically to the location of the meningioma. Examples include fax and parasagittal, impair levels of brain functioning such as in the reasoning and memory. If located in the middle section, it would likely cause leg weakness or numbness or seizures. Convexity may cause seizures, headache, and neurological deficits. Sphenoid, vision problems, loss of sensation in the face or facial numbness and seizures. Olfactory group, loss of smell due to compression of the nerves that run between the brain and the nose. If the tumor grows large enough, vision problems may occur due to compression of the optic nerve. Suprasellar, vision problems due to compression of optic nerves and posterior fossa. Facial symptoms or loss of hearing due to compression of cranial nerves, unsteady gait, and problems with coordination. Intraventricular may block the flow of cerebrospinal fluid, resulting in obstructive hydrocephalus, potentially leading to headache, lightheadedness, and changes in mental function. Intraorbital, build-up of pressure in the eyes, leading to a bulging appearance and potential loss of vision. Spinal, back pain or pain in the limbs caused by compression of the nerves that run into the spinal cord.